So maybe explain to the audience your unique methods of dealing with addiction in your patient population.
We see that their energy level comes back, they're more coherent, they're more willing to get into sobriety. So that's one part of how I try to approach.
So we use different combinations, like anesthesia does specific nerve blocks with ropivacaine, and then we do specific nerve blocks with a combination of basically regular marcaine and then liposomal. Today I have Dr. Esra Cavusoglu, who is a doctor in psychology and certified addiction therapist in the state of New York. She formerly held a position on the clinical advisory board of the Yale University School of Medicine and served as an advisor for international development with the Yale program on supervision. Dr. Ezra has participated in numerous international conferences and events. Some of the prominent organizations include serving as a moderator at the event organized by the Office on Drugs and Crime in Vienna, Austria in 2016. Also, Ezra also acted as a panelist at the Asia Pacific Behavioral and Addiction Medicine Conference held in Singapore in 2013. Dr. Ezra continues to treat her patients. She is established in the Contemporary Addiction Studies Association to combat growth addiction problem in Turkey. In her her desire to spread the science of addiction to the field and support institutions who are in need of residential and outpatient program, as well as creating curriculums. Please welcome Dr. Ezra. All right, everyone, I have a special guest today from Turkey, Istanbul, Turkey, Dr. Ezra, and she has a very complicated Turkish last name that I'll let her say, and I will not say it again. I'll just refer to her as Dr. Ezra. Thank you for hopping on the show this morning, Dr. Ezra.
Thank you, Dr. Robert.
Yeah,
my last name is Cavusoglu.
So that's way different than I would have pronounced. I'm going to say, Dr. Ezra and I were talking offline, previously about her work with addiction and biohacking and longevity. And it's funny because I got sent a text message yesterday by someone and they said, can you speak about cognitive impairment? And I said, yeah, sure. Yeah, I'm cognitively impaired a lot of times. So yeah, I can talk about it. In terms of it and how we see it in our practice, Dr. Ezra, because I take care of patients who are interested in improving their wellness, like you've had your own journey. Part of it is dealing with and coping with whatever, trauma or other problems that have led to and possibly contribute to problems with addiction. So maybe explain to the audience your unique methods of dealing with addiction in your patient population.
Sure. First of all, I'm in recovery myself over 18 years. Therefore, it's much easier for me to connect with the patient by sharing my story with them. And how I approach to them is that a colleague of mine over 15 years ago did a study on a male population who've been using alcohol and or drugs for a long time. Even they're young, their testosterone level was very low. So she got interested into it. She was a psychiatrist. And then after that, she started sending these patients to urologists to be able to test their hormone levels, and they refuse her. They said, like, this person is young, why would I do it? And then after she got back into school again, she did an A4M certification. She's board certified functional medicine doctor. And me working with her, I use her as a, part of my clinical practice as a psychiatrist. Our approach is to not to approach to people who comes to us dealing with their addiction, just talking about their problems or their trauma. What we do first, a comprehensive blood work. And over there, instead of just giving them an antidepressant or anything else, we see that vitamin D level is very low, their hormone levels are low, their thyroid levels are low most of the time because of heavy use. When we fix these, we see that their energy level comes back, they're more coherent, they're more willing to get into sobriety. So that's one part of my how I try to approach approach. The second part is that I actually, to be honest with you, convinced them with longevity, because in my own journey, what I did see, since I've been very interested into this longevity biohacking world for over 10 years, more and more tests started coming out, and I saw that 13 years of using drugs really affected my system so much that all these biological age tests shows that I'm barely now equal to my chronological age. Therefore, I try to convince them, because I have high-profile people or their sons or daughters in their 30s to 40s, and for life is very easy for them. They don't need to make money, earn money. Everything is very available now in Turkey. But because this biohacking and longevity sounds so sexy, and they see me in front of them, this woman is cool. She doesn't look like a normal therapist that we go to. So they got interested into it. So I try to convince them from that angle as well.
Well, then let's go tangentially there, because you first mentioned hormones, and I feel like you probably have to explain it in how it is in Turkey, and I'll just give my interpretation of it here in the United States, which has a lot of it's a huge place, obviously, and the complexity of living here, depending on where you live and what you'd exposed to. Dr. Ezra lived in New York, so she's uniquely aware of the things that challenge you in a city like New York. They're very different, whether it's the air or water or where you're living, getting exposed to things like mold. All these things can affect your hormones, your thyroid function, your sex hormones, and cause what Dr. Ezra is describing as a suppression of those. And certainly in females, because females have such a low amount of free testosterone, it takes very little disturbance of that to cause a significant suppression. But I commonly see, and maybe you can just give us your thoughts about this. I see a lot of people with thyroid dysfunction. Like that's the most common thing.
Yeah, we more see not thyroid, but the other reproductive hormones, let's say. So the pituitary gland, for us, the pituitary gland is not functioning correctly. And I have one patient, she is 35 years old. She got into an early menopause in her early 30s, like 31 years old. She's now over 1 year sober, and her periods came back. But it's very difficult, like these new approaches. You follow a very a regimen that is very comprehensive. You're not just doing operation on people. How I follow life is like that, and it's very difficult. Actually, the most difficult thing is to find a doctor in regular OBGYN and send someone who's 30 years old, 35 years old. They're mostly given synthetic hormones, and you're trying to swap them, and I'm sure you're seeing them as well.
Yeah, that is a very confusing topic for me, because I see a lot of patients who have estrogen toxicity, and because they have problems with their period, they're then given synthetic hormone, which actually doesn't help that problem. So it's a very odd way for someone to try to treat a problem that is more a function of production of toxic estrogen rather than trying to balance. It's not balancing out anything. It's a very strange concept to me, how that has stuck so long with the OB-GYNs, and why they're so resistant to like looking at genetics and maybe looking at more of a specific subset of estrogen and metabolites that contribute to PCOS and endometriosis and painful periods and all these things, and looking at levels of estrone, which I almost uniformly have people come to me and I ask them, I go, did they look at your estrone level or any other levels? And they don't know. They had blood drawn, and they'll pull it up on their phones now because they can, and they'll show it to me. And it may have their estradiol level, and that's basically it, which, estradiol, if we want to be like good, bad estrogen, estradiol would be the good estrogen. But if you're someone who metabolizes a certain way genetically, you'll have more.
I consider myself very, very educated and persuasive, and I had to go through 4 different doctors until to be able to find the right combination for myself. I mean, the one give this much estrogen. I blew up like a balloon. I said, I don't want to take it, but I had to practice what I'm preaching. So I had to suck it up and start using it. Until now, I shall say, like only 4 months ago, they realized through Dutch test, pathways of the estrogen is not working properly. So they gave me extra detoxifying agents so that I was able to take as much as the doctor wants me to use. But I have a question for you actually about, because you do the operation and patients need some sort of a painkiller, I assume. What we see around the world, especially in the United States, 1 out of 5 or 4 addiction patients coming is hooked on opioids or OxyContin, that type of painkillers. How are you controlling it?
Yeah, I mean, it's an interesting question, and every time I have to do continuing medical education or do a renewal of a license, there's a whole opioid educational curriculum, and it's interesting because I've operated in 2026. It'll be 30 years that I've been operating, and we've always used short-term narcotics as a way to treat surgical pain. What I do is called an ERAS. So it's early recovery after surgery. And it's a combination of ondansetron for nausea, an anti-inflammatory, and you can sub in different anti-inflammatories. One's used routinely are celecoxib or naproxen, and you can choose whatever. The other thing you want to do is control for neuropathic symptoms, because neuropathic pain is a really difficult problem for patients. And if not appropriately addressed, and we try to do everything up front. We don't try to respond to it after it's already happened, because it's more problematic. So we treat all of our patients up front with a dose of gabapentin or pregabalin, and then post-op, there is narcotic available if needed, but intra-op, so during the procedure, nerve blocks are done with a combo of short-acting and long-acting local anesthetics. So we use different combinations, like anesthesia does specific nerve blocks with ropivacaine, and then we do specific nerve blocks with a combination of basically regular Marcaine and then liposomal. So the short answer is I don't do anything as I was taught. I do everything to avoid what you're describing, which is problems with post-op. So it's almost universally unheard of for me to have people ask for more pain medicine. And if they do, then we have to be alert to, like, that's somebody with a metabolism issue, because it's very rare that I would have somebody, have an addiction type issue, but you should not have people on short-acting narcotics, beyond, the first week or so after a surgery that we're doing. So we don't see a lot of that behavior, or it's very rare, honestly, because we do so many multimodal things. And then obviously in my clinic, we have hyperbaric oxygen, lymphatic massage, and red light therapy. I mean, we do a lot of things that are, from a anti-inflammatory standpoint, very aggressive to promote recovery.
Because, how I help my patients also is I'm probably one of the only, maybe there are like 3, in the country that are in recovery themselves and also do this as a practice. So I know both sides of the story. Therefore, I really try to educate them. And what we see most of the time, they do not share that they're in recovery with the doctors that they're going. They don't tell you. They don't come to you and say, hey, I'm in recovery. If they're in early recovery and their mind is still in this tricky stage that, oh, it would be so nice to have a couple of pills so that I can get high and it's going to be prescribed, so I'm allowed to take them. And we really try to make them share that information from the get-go, from the first time they're meeting. Hey, I cannot take this type of medications.
Yeah, maybe because that's a complicated mindset,
Yeah.
The addictive, mindset. High functioning folks have a lot of obsessive compulsive, type behaviors. And those types of personalities, not to generalize, but those people have the ability to become addicted very easily to, alcohol or other, substances. And that's not uncommon. Doesn't matter what it is. I've seen like professors be addicted to what you would imagine would be pretty scary, some pathomimetic drugs because they want to stay awake, they want to work. And, that's how some of those things manifest, right?
Yeah. So, when you said high performance people, there is now a third type, I don't want to say third type. It used to be, people used to think like, oh, people want to party, they want to have a good time. Then, therefore, they got addicted. Then there were the second. After that, the researchers started showing that no, actually, they're doing self-medication. They have an untreated depression or OCD or attention deficit disorder, whatever. So they're using drugs. Now there's a third approach: is the performance. Whether sex performance, athletic performance, we start seeing these guys are being hooked on these, steroids, things for their sexual performance. So now, the areas keep shifting, and you need to adjust yourself accordingly.
Oh yeah, I mean it's. I often get people, Dr. Esra, they'll be in front of me and they'll have been put on a hormone, and they'll say the hormone didn't work. I'm like, well, okay. So you're telling me that all the athletes who use drugs, these hormones, use them because they don't work? So obviously, no, right? There's a dose, delivery, target tissue type phenomenon. Either you're not taking a real drug, or you're not taking enough of that drug, or it's not reaching the target tissue that it's meant. So obviously, just like you said, hormones in the athletic world have been abused for decades. That's not. Yeah. And now in our country, we have this thing about peptides, which I'll probably get, chastised for. But peptides, now all of a sudden, peptides are a problem. And they've been used for decades as well without any scrutiny. But now all of a sudden there's scrutiny because you can.
What's like? Oh, tell me, I didn't hear that part. I'm using peptides myself, but so they're abusing it. Therefore, they're getting extra feelings, extra outcome, because I don't feel much of anything when I do them. I can't hear you suddenly. Yeah, I think it's coming now. No, it's good. Yeah, it's gone again. Something happened.
All right, we had a little internet issue. Dr. Ezra's in Turkey and I'm in Austin, Texas. So that can happen. So basically what happened with peptides is the FDA sent out they put it on the dangerous list, which is kind of interesting because peptides are simply amino acids. And we, recently had semaglutide and Wegovy. These are peptides that are used to treat diabetes. And so they're already being used, and they're being used by drug companies. So, of course, if someone feels like somebody's not getting their cut of the money, so to speak, there's going to be a problem. And BPC 157 has been used for decades as a tool to help patients for recovery after injury or surgery. And I'm just using that one as an example. Of course, there's all sorts of others, ipamorelin, tesamorelin, there's trips. There's a whole list of peptides, and of which, like you said, you can use them and not notice anything. Because they're not meant to, alter states of consciousness to me. They're not meant to enhance performance in such a way like a anabolic steroid would. So you're not going to take, BPC 157 and then go to the gym and work out like crazy because it's not going to do anything. So it is interesting that all of a sudden those have come under scrutiny. So basically in our clinic, which used to recommend peptide therapy as part of our program, I stopped because it's not worth the trouble to be in a conflict with what the FDA is putting out in our country.
Oh, okay. So I understand. I thought that you were talking more around the addiction. But actually, you know what? Even though it's really good, these GLP-1 agonists, I feel like people who are having eating disorders, that they might be abusing them.
Oh yeah, of course. I mean, yeah. I mean, I've got skinny people in my neighborhood taking GL1P agonists. Like, why? They're, the once you burn up, for everybody listening to this, once you burn the fat in your face, don't come to Dr. Whitfield trying to figure out how to put it back. That's not happening. So, those types of situations like you're describing they're not uncommon.
Yeah. Do you see how young your patient populations are? Any age variety?
Oh, mostly it's 35 to 55.
I started seeing lately in the young people population 25 to 35, bulimia nervosa and alcoholism going hand to hand, very much so.
Oh, wow. Okay.
Yeah.
I don't see that many younger patients. So the kind of demographic like that would not be in my clinic, because typically, for patients, traveling from whether it's Turkey or UK or Asia in general, they're going to be a older group in general. I will say I've had some people in their early 30s lately, which was concerning, because considering that I am 55, that's like almost operating on your kid.
Yeah. Yeah, me too. I keep saying kids and I'm like, okay, this person is 25 to 30 years old. Yeah. So do you think that they're starting to some sort of body dysmorphia and want to keep changing stuff at an early age, like their breast, their face?
Yeah, for women, I think there's always this concern about looking and appearing too heavy for, still to, for whatever reason. When you're younger, you probably typically will have like a rounder face.
Yeah.
So, I mean, I have had, moms and daughters worried about that. I have some relatively, we have a non-invasive treatment that if someone has a rounder face who's younger, that with one treatment, you can help contour it. I don't ever recommend removal of tissue in someone young. That is just not, that's going to create scarring. And I don't even, surgery is not something you start when you're in your teens or your 20s, if you can avoid it. Like if you had an accident or there's an emergency or something, then well, that's fine. But cosmetic things, I would try to really lean into what are the non-invasive, or if in fact they ran my program and had inflammation for a reason, then they would actually decrease their inflammation. And for everybody listening, fluid movement is the biggest culprit in looking puffy or bloated or anything of that nature, and that can really manifest itself quite obviously with, like diet issues. Like if you're someone who's sensitive to gluten and you eat a bunch of gluten, you're going to get puffy. If you drank too much, if you're out, I'm in Texas, so, margaritas and salt on your margarita is kind of a common. And if you eat that, have that and a bunch of sugary stuff, I mean, you're going to wake up looking like a mess the next day with a swollen face and eyes and everything. So, I always try to get people, checking themselves with their diet and, sleep more than anything.
So what type of non-invasive procedures you do?
The non-invasives we use, the company is called InMode, and the actual devices are Evoke and Evolve, and they're non-invasive bipolar radio frequency devices, and they stimulate some of the skin contraction and fatty layer can be adjusted. And of course, when you're younger, everything works better. So if you're trying to do those facial changes, like one treatment in someone under the age of 25 would be like standard. In someone under the age of like 35, I would just do 3 and wait. And it does work. When you're older and you have skin laxity or changes that we all get, collagen, goes down. It starts going down in your 20s, actually. So it's going to get harder and harder to get a non-invasive or a minimally invasive treatment to give you a result as you age. Those are the facts.
How successful is the Elacor?
Yeah. So,
Skin remove. It kind of removes micro skin removals, correct?
yeah, so that's a microcoring technology. So if I have somebody who wants to come in and have a no cut facelift, which is my collection of or combination of treatments, microcoring, which Elicor is the device that is FDA approved for microcoring in the United States. It takes out slivers of skin that are less than a half millimeter in diameter, so it removes skin. The issue would be like what I just said with a non-invasive. So as you age, the skin gets looser. So there's, someone in their sixth, seventh, eighth decade of life, that treatment is not going to be a standalone treatment that's going to make some visual change. It just can't. So even though you can take skin out, it's still not going to give people this perception of pulling their face back, which is the universal sign of a facelift. Even though your face doesn't age sideways, that's what everybody does. They pull their face back and like, yes, yeah, that's the most unnatural appearance change you could actually have because everybody ages vertically. They're not going to age sideways. So the vector is down towards your feet, it's going south always.
The clientele that I have lately, after I I announced my sobriety on two popular podcasts in Turkey, I started bombarded with families that are trying to hide their names. They don't want doctors or institutions get to know them, and I'm kind of one of them as a family, so they feel more comfortable. I see these young people are really suffering from their addiction, young meaning in their 30s, and unfortunately the shame and the guilt of the parents doesn't allow them to get into recovery. And I see in these young people not only using drugs, some of them having bulimia, but they have an excessive aesthetic procedure chasing mindset. One doctor to the other doctor, like one does the hyaluronic acid fillers, the other one does this, eyebrow lift. So do you ever receive these people that are in their like 30s? And is there any time that you said, no, I won't do this to you because?
No, the thing with everybody knows my practice in my area, and so we are traditionally a natural appearance clinic. So the kind of clientele who wants more toxin and more filler is not our clientele. So they already know not to come here. So that's kind of a self-selection process that we've created and our reputation that we have because I'm very interested in natural appearance. So many people look so strange already due to filler placement that we don't need to add any more to them. So that is not something we see. And then in terms of people who want more and more cosmetic surgery, I no longer address other forms of cosmetic surgery. So I don't do facelifts anymore. I don't do tummy tucks anymore. I don't do arm lifts. So we concentrate on our explant patient population to help them. And then we do have the no cut facelift, and we have some other curated things that are minimally invasive. So we don't see people who want to be continually changing their appearance.
So you told me the other day that you do the jaw contouring. What do you do for the upper face? Because, imagine like someone comes to you in their 50s, you give them a great jawline, but their brow is like not in the place that they should, and their eye area is looking much older than now the jaw. Do you have equipments to fix them too?
Yeah. So basically, for the eyes, I don't do lower lid blepharoplasty anymore. I do the microcoring close to the eye, but not too close. And it works great on foreheads. So instead of doing brow lifting, I would do that to the forehead. I think that's a really underutilized treatment area for microcoring, and it would be off label. I tell everybody, on label is like the, cheap. Yeah. Off label is everything else. I just let everybody know, like, this is the technology. It's here to take skin out. So because the forehead, to your point, can look aged and the brow can be malpositioned and contribute to what looks to be like saggy eyelids, it's
Yeah.
a nice treatment option.
So one treatment is enough? No, do you go aggressive on them so that it's enough, or like how does it work?
It's a function of aging. It's not a function of how many times I have to do something. Everybody shows up at a different place and space in their life, and their aging is very different. It depends on their ethnicity and weight loss, weight gain. You mentioned semaglutide. I have people showing up who've been taking that drug. So everybody's going to be unique, and you just have to meet them where they are and figure out what's going to be best for them. So in terms of folks who, to wrap this up, the things, what would be the good take homes if someone's concerned about addiction, maybe that, or their children? What advice can you recommend? And then where would they go to learn more about what your clinic is doing and what your work is?
Obviously I have my YouTube channel that I have a couple of, it's a variety of topics that I cover, but also there's about addiction. But what they should pay attention to, people come to me and they're like, oh, do you think me or so-and-so is addicted to whatever, alcohol or illegal substance? I said, we don't measure and diagnose based on what they're using or how many times they're using. We're measuring it if their behaviors are changing, their priorities are changing, their feelings, thinking pattern, how they're taking care of their schoolwork or their wife or their children is changing. We're looking into that, and the diagnosis lately changed into a substance use disorder, mild, moderate, severe. In the mild version, everyone can diagnose each other, I think. Moderate and severe, when it comes to severe, unfortunately, it's really dangerous because going back is very difficult at that point. And we see a lot of early dementia, alcohol-driven dementia in their late 50s, women especially. Therefore, I think that when they see their loved one is changing, their friends, they're coming home, eyes, bloody eyes, and they're, hiding in their room, they're depressed. For the kids, they should start paying attention what's happening. Also, they should stop, the loved ones shall stop enabling them, because that's the worst part. They're just like, don't cover up for them. Don't think that they're not having a problem. Don't blame yourself. Maybe you caused it. Try to read scientific literature instead of thinking this is a shame issue. I have a website called longevilab.com. Over there, we're obviously Turkish and English. We have many articles in many subjects as well as addiction. On my YouTube channel, Ayık Kafa, I'm sure you will add to the podcast notes, and you're going to be appearing on mine. The English name is Soberhead. Over there, I'm, every couple of episodes, I'm inviting very well-known faces in the addiction field from the United States. And I'm in Turkey, and they can reach out to me through my Instagram because I'm checking it out and I'm replying to the messages.
That's awesome. Well, thanks for coming on the show today. I really appreciate having you. This is the first time I've had someone who is both taking care of patients with addiction and doing it in a holistic way that helps them with their longevity as well. So thanks for coming on the show today.
Thank you.